Welcome everyone to the Department of Public Health seminar series. Just a reminder to please mute your microphones, and if you have any questions, to include them in the chat. We'll have a question and answer session immediately following Dr. Rogers' presentation. I have the pleasure of introducing Dr. Charles Rogers. The title of his presentation today is it your social responsibility to demolish public health disparities? Dr. Rogers is a tenure-track assistant professor in the Public Health Division of the University of Utah School of Medicine, an associate member of Huntsman Cancer Institute, an associate member of the University of Michigan Mixed Methods Program, and founding director of the Men's Health Inequities Research Lab. Dr. Rogers' research agenda contributes to translational solutions that address the complex underpinnings of cancer and men's health disparities, with a primary focus on colorectal cancer awareness and prevention among African American men for more than 10 years. Dr. Rogers, I welcome you, and the floor is yours.
And thank you for the introduction. It's a pleasure to virtually be here. So as noted, my talk today is titled, Is it your social responsibility to demolish public health disparities? Those are few of my titles that are there. I do a lot. These disparities don't go away because of pandemics. They get worse. So I feel like it's my duty to do something about it as much as I can. So I also like to note that I'm also the founder and president of the Colorectal Cancer Equity Foundation as of March of this past year. So feel free to check that out when you convenience to learn more about that. If I see you not paying attention, I'm assuming because you're tweeting some of the stuff I'm talking about today. So feel free to do that at Sierra Rogers, PhD. So before I get started, I think it's very important that we start recognizing that we're in the middle of this collective grief for something that we lost due to the pandemic. You know, the people we've lost alone, to me personally, they should be more than a number. So I like us to take a moment of silence to acknowledge that. Thank you. Also, I would like to note a trigger warning to help some of you avoid fight or flight modes that occur when you are exposed to words or imagery that remind you of trauma in your life. For instance, racism and cancer will be definitely exposed to my talk, and they tend to affect all of us in some type of way. So I am in full support of practicing self-care and encourage each of you to do so as needed. If you need to take a moment to turn off your screen, step away, I will not be offended. So the game plan for this heavyweight bout today, in terms of your learning objectives, by the conclusion of my talk, each of you should be able to assess your social responsibility to annihilate public health inequities. 2, each of you should be able to illuminate the colorectal cancer or CRC related disparities faced by medically underserved and minority populations. 3, each of you should learn ways to effectively conduct community-based participatory research, CBPR. And also, each of you should be able to identify factors contributing to low CRC screening among African-American men. So who is Dr. Rogers? So I'm originally from North Carolina. Excuse me. I started out there with a bachelor's in applied mathematics with a minor in accounting from North Carolina State University. From there, I moved on to Georgia, where I did a master's in applied statistics from Kennesaw State University. Had a mentor there who really challenged me and felt it'd be a travesty for me to not be in public health. So I went into that space to do a doctorate in health education and behavior from Texas A&M University. Like to learn a little bit. So I went on to do a postdoc in cancer-related health disparities and CBPR at the University of Minnesota. That's where I met dear Dr. Pamela Jo Johnson. But I also did an MPH focus on public administration and policy because I knew I was doing great work, but I feel it wasn't really reaching the people as well as reaching those in positions that can really make policy change. But if you really know who I am, you also know that it's very important to realize that over the past 2 decades, I've mentored over 40 scholars who've achieved advanced degrees such as MD, MPHs, PhDs, as well as positions including postdocs, assistant professors, even associates professors, and I'm not even there yet. Program evaluators, healthcare analysts, consultants, program managers, and even directors. So the many ventures I'm able to take part in, I'm very intentional about making sure that they enable a variety of opportunities for student involvement, regardless of their science and healthcare background. So I'd like to give a shout out to these scholars across the globe, where I would say roughly 98% of them I still keep in contact today. So if you see any manuscripts cited at the bottom of the screen, you see an asterisk, that's definitely one of these rising rock stars right here pictured. So, of course, many of us are aware that it's Black History Month. And, I would be remiss if I were to not give a shout out to one of the grandfathers of the movement in terms of the equity work, Dr. MLK. And nearly 56 years ago, he noted that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So even though he made a statement over 56 years ago, how much progress have we really made in terms of eliminating disparities in public health? So Dean Coots once stated that the world howls for social justice, but when it comes to social responsibility, you sometimes can't even hear crickets chirping. So as I progress through my talk today, I challenge each of you to internally reassess if you are truly acting on your social responsibility to demolish public health disparities. And so I would like to start with a poll to just see where you are at, since you do have this day at home, see if how alert you are today, with the university being closed per se. So on average, which of the following conditions is the strongest predictor of your health? Who thinks it's A, whether or not you smoke, B, what you eat, C, whether or not you're wealthy, D, whether or not you have health insurance, or E, how often you exercise? 10 seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. So I see that there is a split between some thinking it's what you eat, some thinking it's whether or not you have health insurance, but the majority of individuals think that it's whether or not you are wealthy. C is indeed correct. The wealthier you are on average, the better your health from the bottom all the way to the top. Genes, diet, exercise, and other behaviors are important, but a poor smoker still stands a greater chance of getting ill than a rich smoker. So the answer to this question reminds us of the power of social determinants of health that many unfortunately fail to consider in their research. So the principal drivers of injustices in the health system stem from social determinants that govern the health risks and preventive behaviors, access to and affordability of healthcare among socially disadvantaged groups. From a social justice standpoint, addressing this disparities in our various areas of research are key to improving our nation's economic prosperity and overall health. So with me, in terms of health disparities and determinants of health, I like to think of the determinants of health as like an iceberg. Most of us know about the iceberg because of the Titanic, whereas like the things that are on top seem like they may not be too big of a problem, but the things that are below is what can take us out. So if we look at that more granular and look at social determinants of health as defined by WHO, the World Health Organization, they define them as the circumstances in which people are born, grow up, live, work, and age, as well as the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces, economics, social policies, and politics. I even like to include that we could have to consider where people worship is also a social determinant of health. But if we were to look at health in general, for the purpose of my talk, I'll be focusing on CRC. Things that contribute to the disparities of CRC as well as other health disparities are education, health services, income and social status, gender, culture, racism, not race, physical environments, and other entities. I would like to note if you have any questions, feel free to drop those in the chat, and we will definitely discuss those at the end of our talk. So growing up in the Black community, I never heard about colon cancer. I only heard about prostate for Black men and breast cancer for Black women. Well, if I were to slow down some and look at some things that I may have seen on TV, there were some discussion back in the day about colon cancer, but I may have overlooked it. And here's one popular clip from a film a number of years ago.
Did he? Did he ask for my digits? Come to hospital. You just gonna come up here and bring me like I'm a kid to the hospital.
You got diabetes and you wasn't feeling well, and I brought you to the hospital.
Well, I feel well now. Can we go?
Good day.
Good day, doctor. How you doing?
Very well, thanks.
Good.
Now, Mr. Brown, you have to take your insulin.
I've been taking it.
Now, are you eating right?
Yes, sure. I mean, right. Yes.
No, he doesn't. He's lying.
Corey, ain't nobody. You don't call me no lie. I'm your daddy. You gonna sit there and look in my face and call me no lie. You don't know what I eat.
I know what he ate. He ate 10 pieces of bacon, 3 eggs, a biscuit, and a pork chop with jelly and orange juice.
Just for your information, that's where you lying, because I don't even eat pork. I ate ham. Thank you.
See, the problem with a lot of people is they think diabetes is just a little sugar. It isn't. Now, you have to eat right.
He don't do that.
You have to exercise.
He don't do that.
And let me tell you something. There are people who have lost their eyesight, their limbs, and even died from this disease. Now, you got to get serious about this, huh? Lose some weight. Start exercising, or things could get worse.
Exercising, losing weight.
I am. Doctor, I hear what you say.
Are you listening to what he's saying?
All right, didn't I just say I hear what he's saying? Now, you're going to make me whoop you. Get you some business. You need to get you a husband. Maybe that'll keep you out of other people's business. You married, doctor?
No, sir.
Cora ain't married neither. Why don't you ask her to marry and y'all live happily ever after in the forest or something? So she can leave me alone, stay out of my business, stay out of my matter function.
Now, Mr. Brown, I've also noticed you never had a colonoscopy.
Oh, yes, that's where you're wrong. I drink colas all the time. I like colas with ice and everything.
And he shouldn't be drinking colas. There's too much sugar in the doctor.
Cora, you too much sugar, looking like a bag of cotton candy. Cora is the snack demon. That's right. I caught her one day sneaking to get some chips. Under your bed, I found them chip bags. And she got soda water bags and cups and everything under her bed. How many Oreos would this be? You know how many it is? Tell me.
You know how many.
5 Oreos. You can tell me because you tried to tell me the other night.
We're not in here about me.
Now, Mr. Brown, I do have to tell you that you are well past 40 now.
Way past.
Well, I ain't that much past. You trying to make it seem like 40's down there, and I'm way back. I'm close to 40. I mean, 40 over there, and I'm right there. You make it seem like I'm old or something.
The point I'm trying to make is that you should be having regular colon and prostate exams. It could save your life.
Okay, you go ahead and check my cola and my prostitute record.
It's prostate, Mr. Brown.
Cora, I know. It's the same thing. Just go ahead and just check me. Hold on. I had some of Cora's chips I found, and I may have some on my prostate. Go ahead and check.
Not that end, Mr. Brown. The other end.
You talking about my beginning and the end?
Yes.
The devil is a lie. You can't be back there like that. Wait, doctor.
Get him, doc.
Wait. I'm new. Please.
How many Oreos this may be? So there's so much that you can take from this clip in terms of what was keeping Mr. Brown, from potentially getting a screen for CRC. There was lack of knowledge, there was fear, there was a masculinity piece. There was even the piece in terms of the social support that he did get from his daughter. We think about any type of behavior we're trying to change. If someone close to you is for behavior, there's more likely a chance that you will actually do that behavior. And so these are one of the first instances, where I think back in time that I saw some focus on colon cancer in the media, but in terms of it being eliminated, I didn't really see it until I got a personal experience myself. So growing up in rural North Carolina, I never heard about CRC, and my family was very big pre-COVID on having family reunions. We have generations that get together, do numerous things, increase your risk for CRC, such as consuming alcohol. I see my uncle here doing that, eating processed foods like hot dogs, etc. smoking, but also doing some things that decrease our risk, such as being physically active. Where our family's really big on dancing, line dances like cha-cha slide, Cupid shuffle, etc. And so during that summer of 2009, we had noticed that my aunt had lost a lot of weight. So we just figured like, oh, okay, maybe a joint is eating better, etc. Well, we fast forward about 3 months later, and she's misdiagnosed 4 to 6 times from 2 major healthcare systems in North Carolina to find out that she has stage 4 CRC. Well, catching CRC early, say 0 or 1, an individual has a 90+% chance of survival. But at stage 4, like my aunt at that time, she actually had a less than 10%. Those numbers now are about less than 14%. But at that time, she was diagnosed at age 52. So at that time, too, the screening age is recommended to be 50. So she had got screened at that age. Maybe potentially she would have been here today, but she was able to fight this disease, preventable disease, for about 8 years. So I was able to learn so much from her, and I always like to give her a shout out when time permits for helping me find my purpose. But shortly after that diagnosis of my aunt in 2009, while doing my doctorate at A&M, I did some work in Michigan with Chief Colorectal Surgeon Arden Murs, was trying to figure out why Blacks would get surgery, but they wouldn't get chemo. And she felt it may be something that may be resulting from poor patient-provider communication, other determinants of health, et cetera. But when I went broader with the view, looking at cancer itself, after looking at literature, if we focus on the rates of death from cancer among white men across the country, look what happens when we focus on Black men. So we'll look for the changes on 3. 1, 2, 3. What changed? I'll go back one more time and people
moved away from the South.
Awesome. That is definitely what happened. It moved away from the South. So people that may be still sleeping, I'll do it one more time on 3. 1, 2, 3. What else changed? Did anyone notice anything else changed?
More?
Mortality rate increased by about 100.
Right.
Excellent. Those answers are all correct. The mortality rate increased substantially. If you were to just even focus on Utah, it went from basically nothing and jumped 2 spots. There was definitely darker shades of red across most of the states, and there was definitely more red concentrated in the South, as mentioned. So, but in terms of why I focused on Black men for most of my career, which has been over a decade, based on the American Cancer Society's cancer facts and figures for Blacks and African Americans that just came out last week or so, for me as a Black male, I have a 21% higher chance of getting CRC than a white male, and a 44% higher chance of dying from it. Again, I have a 21% higher chance of getting CRC than a white male, and a 44% higher chance of dying from it. But the problem doesn't stop there. If we look at their Black males, female counterparts in terms of Black women, you can see that they have the highest chances of getting CRC and dying from it compared to their female counterparts. Also, as of today, Black women remain 31% higher in terms of their chances of getting CRC compared to white women. And then 18% higher, and mortality is actually 31% higher. But again, in terms of Black men, I've actually focused on them because we can also see here that Black men have the highest chances of getting CRC and dying from it compared to everybody, males and females. So one key take-home message that you definitely need to remember from this talk is that CRC is preventable and curable with early detection screening. Yet disparities across the country exist. So when I was in Minnesota, it was very common to see type of billboards like this down the highway, big or small. You want to see them all, get a colonoscopy. And a colonoscopy is a form of screening for CRC, and screening for CRC really focuses on effectively testing to detect precancerous polyps so they can be removed before turning to cancer. So despite, states doing campaigns like this, how much progress are we actually making in terms of eliminating disparities? Well, with the National Colorectal Cancer Roundtable, which I am a member of, our current commitment is to challenge all states to get 80% in every community by 2025. This continues the progress and commitment that we have from 80% by 2018. And so with this specific campaign, we really focus on getting 80% screening rates in every community. So that's 80% for Blacks, 80% for white, 80% for Indigenous, et cetera. But how much progress are we actually making there? If we were to look at it, a few states, as relates to the purpose of my talk today, if we look at Utah, you're like, oh, okay, they're doing pretty good. Their statewide screening rate is 72%, but they're not. If you were to just focus on Blacks, whose statewide screening rate is about 53%, that's nowhere close to that 80%. If you were to transition over to Minnesota, you can say like, oh, okay, Minnesota's doing well because their statewide average is 73, but you see no one meets that except whites at 74. Blacks are roughly 59. American Indians and Alaska Natives are about 55. And with Minnesota having the largest Somali community, their rates are unfortunately below 30%. But the problem doesn't stop there. If you were to even look at places like Ohio, in trying to reach 80% in every community, you can see that African Americans still have the lowest rates, and whites are actually doing poorer than Hispanic Latinos in their state. Well, there's been a debate, for a number of years in terms of the recommended screening age for CRC. And so in 2000, American College of Gastroenterology recommended that routine screening begin at age 50 for those at average risk. We'll focus on men for the purpose of this talk. And at that time, it was recommended that individuals get a FOBT, a fecal occult blood test, a type of stool basis in for CRC annually, a sigmoidoscopy every 5 years, or a colonoscopy every 10. So, ACG, they're typically the first organization to make CRC screening related recommendations because they're working on colons pretty much every day and all the time. So it wasn't too much of a surprise that 2 years later that these recommendations for CRC screening were published by the United States Preventive Service Task Force, such that, insurance companies, et cetera, were required to cover CRC screening starting at age 50, for individuals. Well, in 2008, ACG, American College of Gastroenterologists, actually recommended that the screening age be lowered to 45 rather than 50 for African Americans because African Americans get CRC earlier, as well as at a more advanced stage. Well, it wasn't until 10 years later in 2018 that American Cancer Society recommended that the screening age be lowered to 45 rather than 50 for everyone, because they saw that since the mid-90s, there's been a 2 to 3% increase in CRC among those younger than age 50 since that time. Well, during the pandemic, October of 2020, the task force finally drafted a grade B recommendation for CRC screening for adults aged 45 to 49. And so with this, they continue to definitely recommend screening in adults 50 to 75, as they did before. But again, here, they're recommending that the age start at 45 instead of 50. So as it did in 2016, the task force continues to conclude that screening adults aged 76 to 85 should be an individual one with a C grade recommendation, and screening should be discontinued after age 85. Well, in 2021, March specifically, ACG recommended that the screening age be lowered to 45 rather than 50 for those at average risk. And then finally, in May of 2021, the task force put forth the new recommendation of 45. So 45 is a new 50 as it relates to colon cancer screening. Please share that information very far and wide. But I wonder, and I challenge each of you to ask yourselves, is 45 low enough as we continue to see the trends that are out there? So if we look at age 50 plus, we can see that there's been substantial progress in terms of the chances of getting CRC for these age range are continuing to decrease, as well as the mortality or the death rates are decreasing as well. that when we look at incidence and mortality, we can see that for ages 20 to 49, that the rates continue to increase at exponential rates. A paper came out recently confirming that by 2030, for ages 20 to 49, colorectal cancer is actually expected to be the #1 cancer killer for this age group. So CRC was in the spotlight during the first year of the pandemic due to the shocking death of Brother Chadwick Boseman, most known for his prominent role as a key actor in the Black Panther. Brother Chadwick was diagnosed with stage 3 CRC at age 39 and died in August 2020 at age 43. If me and many others could have things our way in the CRC community, Chadwick would have celebrated his 45th birthday this past November, and his wife and families would have been there to celebrate it with him. This is simply unacceptable. So in terms of some of the ways that I've tried to bring more awareness to disparities in CRC, there's been quite a bit of work I've been doing. So for this work here, our team considered individual and county level CRC outcome determinants to identify hotspot areas across the U.S. So these hotspots are counties where CRC is on the rise, and for this one specifically, killing young men at very, very high rates. So our analysis of counties with a high rate of early onset CRC included men ages 15 to 49 years of age. As you can see, we found that many of these new diagnoses were occurring in counties in the lower Mississippi Delta area, Eastern Texas included, West Central Appalachia, as well as Eastern Virginia and North Carolina. We observed that although roughly 14% of all U.S. adults are current smokers, 24% of the adult population residing in hotspot counties reported currently smoking and having smoked at least 100 cigarettes in their lifetime. And smoking is definitely a risk factor for CRC. Of note, Chadwick Boseman's hometown of Anderson, South Carolina, is a hotspot that we found. So some of my more recent work funded by the V Foundation for Cancer Research is called iBeat CRC. And iBeat, this official logo here was released early this year, tended to be based on the dove alone, a symbol of triumph and freedom for our friends far and wide who beat colorectal cancer, as well as those who beat it on the other side of heaven. So over the past 20 years, the number of Americans under age 50 who are diagnosed with CRC has doubled. Thus, this study is really focused on better understanding the reasons why people under age 50 in Utah are being diagnosed with CRC. In this ecological study, we aim to identify and characterize early onset colorectal cancer hotspot counties in Utah by examining early onset incidence and survival variants explained by personal and county level factors, similar to the techniques that we use for our larger study. So this work is currently under review. So thanks for keeping it on the reps. Of the 1,856 early onset colorectal patients aged 18 to 49 years with CRC between 2000 and 2020 in our study, those living in hotspot counties had notably worse survival with a 31% higher hazard of CRC-specific mortality compared with their counterparts in cold spot counties. Outcome determinants were specific to patients diagnosed with CRC, which varied across counties. Up to 34% of the counties had higher incidence of mortality relative to other counties in Utah. In brief, Utahns with a late stage early onset diagnosis who lived in the 10 counties we designated as early onset colorectal cancer hotspots are at increased risk of dying, emphasizing the need for researchers and healthcare providers to better understand how to serve these communities. So in terms of the early onset phenomenon, the verdict has not been made in terms of what's contributing to this major issue. Some from our previous work was thinking that it was contributing to smoking, as I mentioned. Some think that it's the obesity pandemic. Some think it's something happening with the gut biome in terms of what we're eating every day. There's some hypotheses about it relating to high fructose corn syrup consumption, which we take from sodas. But even from my work, I know many individuals who don't have any of those things that are of concerns in terms of them being very healthy individuals, just running marathons, et cetera, and they're still getting early onset CRC. For this study here, We found that age and race or ethnicity were predictive of CRC incidence rather than hotspot classification. And also we found that more divorced, separated, or widowed adults and fewer single or never married adults and fewer adults with obesity characterize hotspot compared with cold spot counties. So if you do know a little bit about Utah, when this does come out, it's going to cause a lot of noise because like Summit County, that's Park City, that's where everyone from around the world comes to go skiing, is a very nice and wealthy county. I imagine that, you know, these people that we're losing to early onset are not getting much attention. So hopefully when this is released, this will cause a lot of noise, just like our other hotspot study did. So, you know, a lot of people know me in Minnesota because I had this huge study at the state fair. So you all are not too far from Minnesota. So you're aware that the Minnesota State Fair is the second largest in the country. Millions of people go there. And so I felt that it was a great place to have a study. So one of my studies called Colon Cancer, I Prevent, I Treat, I Beat, with a little I stemming from individuals took surveys on iPhones. This was held over 7 days. Over 50 staff from the university and community were involved. And we had over 24,600 individuals that went through the inflatable colon, which I like to call the super colon. So back then, the super colon wasn't that big as it is now. So this was a huge hit. And this idea came from, you know, I'll talk briefly later. I was doing some work in Africa, in Kenya specifically, where, you know, we would have a community fair with free services and we would see over 1,000 people in an 8-hour day. And so it really made me try to think out the box in terms of how I could really reach other people, even though I was only focusing on Black men for this work. So the purpose of this study was to test a conceptual model of factors influencing intent to screen for CRC among African-American men ages 18 to 65 in Minnesota, employing online survey research methods. So the central hypothesis was that, one, male role norms of masculinity indirectly influence these men intent to screen via perceived barriers. And two, these men lack the appropriate knowledge and espouse negative attitudes towards CRC screening. Well, when doing community engaged work, it's very important to be sensitive about the topics that you're trying to explore, as well as what's going on in the world. So at this time, a lot of Black men were really getting killed by cops. And that's when the Black Lives Matter movement really started. And so I felt it was very important to have more positive figures of Black men on market materials versus what they saw in the news. You know, the color for colon cancer is blue. So that's maybe something you may not have known. You know definitely what the color for breast cancer is pink. You know, the awareness month is October. Well, the awareness month for colon cancer is March. And you will see me everywhere on social media talking to making sure people know that. But anyway, you know, with this piece, it's also key to have, you know, simple language that the public can understand. So here you can see that I asked, did you know that African-American men have a 50% higher chance of dying from colon cancer than white men? Being a master certified health education specialist, theory drives of all of my work. So building on the theory of planned behavior, which I've been using for a number of years, my team and I were thinking that male role norms indirectly influence Black men's knowledge about CRC, as well as those recommended screenings I mentioned earlier, which could influence their intent to screen. Another route could be through attitudes. Another route could be perceived subjective norms, which is very similar to social support. And other routes could be through perceived barriers. Those perceived barriers being fear, fatalism, poor patient-provider communication, et cetera. And then we can't forget those determinants of health I mentioned earlier in terms of demographic characteristics, such as, you know, where you live, if you have a job, if you have health insurance, et cetera. So some of the significant findings from this work is that, as we expected, age had a positive coefficient, consistently indicating that as individuals got older, the more likely they would get screened. Perceived barriers had a negative coefficient, which meant that the more barriers an African-American male perceived, the less likely he would get screened. And perceived subjective norms had a positive coefficient, indicating that the more social support an African-American male has, the more likely he will get screened. Well, at the same time we were doing this work, my team also was looking at the relationship between social support, racism, and masculinity as it relates to Black men completing colorectal cancer screening. And so what we found is that a lot of people were doing work in social support, but we argued that additional research was needed that should be extended beyond providers to patient navigators who can facilitate improved CRC screening for African American men and to foster empowerment as well as trust. With racism, there were only 2 studies that were done, and both of these being qualitative in nature, where we argue that there's a need to impact the confluence of factors that place medically underserved African American men with few socioeconomic resources at increased risk for delayed CRC screening and related to similar outcomes. They definitely should be explored further. And with masculinity, there were also only 2 studies that were done, these 2 qualitative in nature. And we argued that a conceptual framework was needed that leveraged the strengths of masculinity and moderated concerns African American men may bring to make cancer screening decisions. With any of my systematic views and meta-analyses, I also like to grade studies. So for this study, for the methodological quality scale, or MQS, studies could get up to 19 total points. And so for this, the average score was about a 10. So that shows that the studies were average quality, but only 1 study exclusively focused on African American men, and only 37% reported any validity. So that's something to definitely consider in terms of next steps. And that's something that I did. But something that really bothered me was that this masculinity piece, it's things that guys joke about in terms of the screening for CRC as well as prostate cancer. People even get them mixed up. But I just really felt that this had some influence, even though it wasn't becoming significant in my work. And so I thought about what's a route that we can go to reach men who may have masculinity barriers to care as well as CRC screening. And I thought about the barbershop. So a barbershop is definitely a pathway for reaching African American men who are not regularly obtaining CRC screening, because barbershops are trusted, community-based, culturally appropriate venues for information sharing within African American communities. A barber tends to have an average relationship with his client of 7 years. And you can even see from this photo that the demographics are far reaching in terms of age, as well as socioeconomic status, et cetera. Due to COVID, I actually expanded to churches, as some barbers, specifically here in Utah, were not used to being community leaders. So that's just something I wanted to know. But with this work, this is my KO1 study funded by NCI for about $900,000, focused on developing a barbershop-based trial on masculinity barriers to medical care and CRC screening uptake or completion among African Americans using a mixed methods approach. That's a pretty long title. So the short title is called Cutting CRC, like cutting hair. So the goal of this work is to design and pilot a theory-driven, culture-specific intervention on masculinity barriers to medical care to improve CRC screening uptake among African American men beginning at that age 45, which is finally a recommendation by the task force, up to 75. So with the first part of this study, which is occurring in Utah, Minnesota, and Ohio, we had focus groups, which are called chat and choose, is what I call them, chat and choose, like talking and eating. The purpose of this study was to examine the influence of psychosocial determinants of men's health on CRC screening uptake among African American men in the 3 states. At this time, you can see that the rate had increased. Black men had a 52% higher chance of dying from CRC than white men. You still see this trend of blue in terms of studies, in terms of incentives. I like to do raffles or drawings. What is called in terms of raffle or drawing depends on what's legal in the state. In Utah, for instance, drawings are illegal. So that's what we use, but I do drawings for things that men's like. So like basketball tickets to see the Jazz or money or cash or TV. But I also gave everyone free food and a $20 gift card. Something else I'd like to note about this marketing material is you'll see my face. And my face is not here because I wanted to brag about this work, but because the community, specifically here in Utah, said that I was the first Black individual to ever do this type of work. So it's been very important for my face to be everywhere. So you'll see it here. You'll see it on cuttingcrc.com. And this feedback is also what I received in Minnesota and Ohio as well, in terms of the importance of having that. So from April 2019 to August 2019, 11 focus groups were conducted across all 3 states. 84 African American men participated. And, with this work, we met the community where they were, so we had these focus groups in libraries. We had them in churches. We had them in the conference rooms of hotels. We even had them in barbershops. But when we asked these men, what kinds of things might cause them not to visit a doctor for care, you see mistrust is huge. There was cost, there was pain, don't want to know, take care of yourself. One of the participants stated, when you're dealing with life and death, when you're in your 60s, you're not thinking about getting a guinea pig, you want to be healed. There was an issue of self-reliance, and self-reliance is resolving their own issues by self-treating and self-educating. One of the participants also noted that I think we've made convenient excuses for ourselves for not going to get checked up. When we ask these men what kinds of things might make an African-American male less likely to obtain a colonoscopy, again, you see mistrust, you see fear, you see cost, you see racism, you see having a good doctor. There was even a fear of weakness. One of the participants stated, we've been raised to be the strong masculine man and not care, let alone understand what is going on with our bodies. With mistrust, one of the participants even noted, I don't trust them old white boys. I think about Tuskegee and all the other things. A lot of times, I really don't think that they specifically being white doctors, care whether I live or not. So I think it's key to take a brief intermission to highlight how medical mistrust, academic mistrust, you can pick which one you want, is very, very far reaching. So, a few years ago, I conducted some important community work in Minnesota, Alabama, and California to explore the perceptions of prostate cancer within the Black community, attitudes towards participation in prostate cancer research, as well as to aim to establish community-derived research priorities in these areas. And so here, too, you can see that healthcare system mistrust was the most common reason in terms of a barrier to prostate cancer research participation. This was expressed in all 3 states. There was concern over historic abuses of Black men in research, such as the Tuskegee study. So a participant in Sacramento stated, the thing that happened, they gave all of these guys syphilis. That has been a black mark on the medical society and the relationship with African Americans, especially men, and it has not changed in terms of being able to be trustworthy for doctors. Another barrier was the patient-provider relationship. The participants noted that having a Black doctor in of it itself was not enough. They noted how mistrust goes beyond an individual physician to the health system at large. There was fear, again, of being treated like a guinea pig, which you just saw similar language in my CRC work, with mistrust stemming from beliefs that researchers hold sensitive motives for Black men in research. There was also even concerns about the security of the data and HIPAA being violated. In terms of facilitators of prostate cancer research participation, the participants noticed it was very important for research to be transparent. A participant in Alabama noted that if it is true constructive research done by doctors with integrity, then I don't have a problem with it. Without research, then we are not going to find out about it. We need to have some testing. Receiving results after research study participation, which is something that I always do. This is a facilitator of research participation. And also another facilitator is bringing more awareness to prostate cancer disparities. A participant in Minnesota noted, you all should be interested because it's killing us. It's killing us faster than everybody else. And they don't know why. That's my whole thing, because I would love to know why, but they said they just don't know why. So this is something that we ended up coined as the Tuskegee effect. So with Tuskegee, this is something that happened in the fall of 1932, over 89 years ago. Flyers began appearing around Macon County, Alabama, promising colored people special treatment for Black blood. So I won't be able to go into more details because of time, but this piece is picked up by NPR when it came out, and the article is called "Distrust of Healthcare System May Keep Black Men Away from Prostate Cancer Research." But definitely feel free to learn more about this article in a special issue in American Journal of Preventive Medicine. So, but mistrust doesn't stop there. We've seen it even occur as it relates to with COVID, not only getting the vaccine, but disparities that are there in terms of life and death as well. And so, I haven't been in the space with COVID too much because I can't make a career out of COVID, but I have been in it in terms of trying to make an impact and clear up the lives that some people make in terms of why Black and brown people are dying. So very, very early in the pandemic, when the current president was preventing public data from CDC and other places to be out, and et cetera. My team did some very, very tough work in less than a month for this special issue where we basically confirmed that more Black people were dying because they held essential worker positions. So with that, we really were trying to bring home that, we know essential workers are very needed, but are their lives essential? And so with this, some key things we noted that it's although our findings showed state-specific occupational differences in states with denser Black populations, they consistently showed that the disparities in Black-white mortality were high, not only in COVID-19 hotspots, but also nearly everywhere across the U.S. This was a very I would say somewhat fun piece because we were really offered, welcome to say what we wanted to say. And so we know that while it was evident that COVID-19 does not discriminate, the same cannot be said about the U.S. healthcare system. And at that time, we weren't able to confirm this due to a lack of COVID-19 specific provider level data, but overwhelming evidence exists that racial ethnic minority patients continue to receive worse healthcare than non-Hispanic white patients. And so again, with this, we also noted that the racial disparities among essential workers in the U.S. that we highlighted are a byproduct of longstanding systemic racism and structural inequalities, combined with a lack of public policy aimed at protecting the lives of essential workers who risk their lives daily to protect others. So this has been the most cited piece I've ever been on. As of this week, it's been cited over 135 times. And so even though it was a lot of work, and a lot of hard writing that we did, I am proud that it's been far-reaching. But to get back to the CRC narrative for today, for my own work, medical mistrust, which used to be here for what I was proposing, it was so evident in every response to the questions that we asked for those focus groups that it's now actually a piece of the masculinity barriers to medical care scale that my team has developed. So with this, masculinity barriers in medical care has been broken down to these other constructs in terms of the role of men feels they need to play as the provider of the family, self-relying on their health, minimizing health problems, restricting their emotions, a fear of being perceived as gay for exams below the waist, as well as medical mistrust. And you'll see those other factors in my model from like the state fair work, et cetera, and how they still play a role. But at the same time, during COVID, because I just had to get creative, couldn't do community engagement, so I got to find other ways to write. My team put out this piece stemming from the focus group data where we identified barriers to and facilitators of recruitment of adult African-American men for colorectal cancer research. So this is an instrumental exploratory case study in a special issue in JCO Oncology Practice focused on disparities in cancer care for Black people in the U.S. So from my own experience, there are numerous factors to consider when you're trying to recruit Black men for research as well as clinical trials. And here's a preview of that.
Thousands of research studies and clinical trials are conducted each year. However, racial and ethnic minorities remain underrepresented. Thus, a better understanding of minority recruitment into research studies is critical in making research more relevant and improving health outcomes. Colorectal cancer, also known as CRC, is of specific interest because 1. African American men have a 47% higher chance of dying compared to white men. And 2. Research on recruitment strategies for CRC-focused research for African American men is very limited. Led by Dr. Charles Rogers, community members and researchers from the University of Utah, Ohio State University, and the University of Michigan conducted an instrumental exploratory case study examining successful and unsuccessful strategies for recruiting African American men across multiple states in 11 focus groups about CRC screening. The study was designed to examine the facilitators and barriers to recruitment of African American men aged 45 to 75 in a qualitative CRC screening promotion study. Recruitment procedures made use of meeting participants where they were, culturally tailored marketing materials, partnership with community-based organizations, churches, and barbershops, as well as food and incentives. The research team found that community partnerships and the location of focus groups were key recruitment facilitators. However, barriers to recruitment included limited access to public spaces, transportation difficulties, and medical mistrust leading to reluctance to participate. The use of strategies such as prioritizing community relationship building, partnering with community leaders and gatekeepers, and use of culturally tailored marketing materials can successfully overcome barriers to recruitment of African American men into clinical trials and cancer-focused research studies. Future researchers can broaden recruitment of this often hard to reach population even further by strengthening community ties and employ multifaceted approaches to address specific barriers such as medical mistrust and economic challenges. Thousands of
So here's an overview of what cutting CRC looks like. So, there's two main objectives. The first one was validating and testing a culture-specific scale using qualitative and quantitative methods. And the second is to develop and pilot a two-arm intervention using mixed methods. So guided by the theory of planned behavior and the behavior change wheel, this is more commonly used among implementation scientists. We had those focus groups, and then we had cognitive interviews by 10 early onset colorectal cancer survivors. Then we had expert item review by two leaders in Black men's health and one international leader in survey research methods to develop the MBMC, the masculine barriers in medical care scale. So the idea was that since Black people outpaced everyone in terms of the use of smartphones, that we would have this scale combined with my other psychosocial work to test it through phones and barbershops. Well, COVID came and said, no, you're not doing anything in the community anywhere. So we had to get creative and, thanks to some other funding, I was able to expand this to Black, white, and Indigenous men. I'll talk about that briefly. Some of that work is still under review. The psychometrics piece with the scale is out. But we were able to, inform this objective 1B here. And so where we are now is currently integrating the objective 1 results. I'll share that shortly. And I'm getting input from the community, not only via Zoom, but even in-person meetings with barbers in the 3 states. And then from there, the goal is to employ the two-arm intervention where one arm will really be driven from the evidence, like from the systematic review that I'll talk about shortly, and the culture-specific arm will really come from the people and the data. And then from there, we'll have post-intervention interviews with participants, barbers, et cetera, to see what we can do to create something that's for a bigger study like an R01 that's sustainable, that, was aware of costs. We will ask the participants like what we can do better, what they didn't like, et cetera. So as we consider solutions to get closer to what cutting CRC intervention, the two arms will be, it's worth highlighting one additional study. So our systematic review and meta-analysis synthesized the literature to evaluate the effectiveness of interventions on CRC screening completion among African-American men. And we found that our final sample comprised about 41 studies, but only 2 exclusively focused on African-American men. And so with these studies, I also like to note that what a lot of interventions do is they group all the Black people together. They group all the Indigenous people together, all the Latinx folks, et cetera. And even as I mentioned earlier with the iceberg, with social determinants of health, I would argue that gender is something that we must consider and stratify in our work. So with this review and meta-analysis, the most frequently adopted interventions were educational materials at about 39%, stool-based screening kits at 14%, and patient navigation at about 11%. We found that most RCTs or randomized controlled trials, they failed to provide details about the blinding of the participant recruitment method, the allocation of concealment method, and or the outcome assessment. In terms of the meta-analysis that was conducted among 17 eligible studies, it revealed that interventions utilizing stool-based kits or patient navigation were most effective at increasing CRC screening completion. Also, when designing and implementing future multi-component interventions, we found that employing 4 or fewer intervention types may reduce bias. So as I mentioned on my slide before the previous one, this is where we are now in terms of integrating the results from Objective 1. So, in terms of mixed methods, because as mentioned in my intro, I'm a associate member for University of Michigan Mixed Methods program, which is one of the top ones in the country. Mixed methods is not just doing qualitative and quantitative work. The key to mixed methods is actually integrating. So here, just showing you some behind the scenes of this work under construction for this design that I'm calling, it's very novel. I'm calling the Agile Convergent Exploratory Sequential Design. And so you'll see here, we have phase 1A with the qualitative work with those focus groups to really expand the MBCS. That's what it was called at that time. to create and refine a new scale, which was ultimately the 24-item masculinity barriers to medical care scale, NBMC. As I mentioned before, we had the scale validation with the cognitive interviews and expert item review. From there, we incorporated theory and built the survey items to get to phase 1B, where we indeed had that validation survey, which was focused on CRC screening intent and uptake among Black men in Ohio, Utah, and Minnesota. But because of COVID, we had to get a little more creative, but make sure that we were still getting great data. And so we did 3 other studies in partnership with Qualtrics to recruit over 900 Black, white, indigenous men across the country to do a study focused on intent, a study focused on uptake, and a psychometric study to help us ultimately get a new masculinity barriers to medical care scale 2.0. And that one's about 18 items. From there, we merged these 1A and 1B findings. We enhanced the masculinity barriers to medical care scale, and we transferred our findings to broader populations to end up with these key findings here in phase 2. So the barriers that we found that you've seen from my talk so far is masculine role norms and medical mistrust, facilitators really being normative and social support. With those facilitators, specifically for Black men, was coming from age, knowledge, fear of barriers and masculinity barriers to medical care, health-related self-reliance. But in terms of barriers, those being negative attitudes towards medical professionals and exams below the waist, as well as being strong. I like to note with this being strong work, we're currently collecting data in Florida, New York, and Texas to look at our masculinity barriers to medical care scale compared to the traditional machismo language or scales rather among Latino men in these states. Community advisory board piece is still being collected. Behavior change, will utilization is still being determined. And those items from the systematic review and meta-analysis that I mentioned, they are also being considered. And these will more than likely be employed some way in terms of the arm 1 of the intervention. And arm 2 will really come from the community and these findings. And so with these methods and theoretical integration, we have embedding of the findings, we have incorporating theory from the behavior change wheel. We're exploring the findings from the review and meta-analysis, and we're even connecting a sample from the intervention into an interview group, and that'll be through these post-intervention interviews. So as I begin to close, I'd like to note that in order to improve the health in North Dakota or anywhere else, a multi-pronged approach must be taken. So for instance, thanks to my MPH, focus on public administration and policy. It really taught me how to get out there and be in the scene in terms of speaking to the community and policymakers in a way they understand. And so it's been very important to me to shift political paradigms across the country. This photo here is pre-COVID in terms of actually being at the Capitol and talking to senators about lowering the screening age and, providing more funding for early onset researchers. It's involved training colorectal cancer survivors to be advocates in whatever sphere of influence they're connected with, and even also includes writing op-eds like this that your great grandma can read. And so, for instance, in this one early on, in Men Post, it was focused on noting that Minnesota should lower the recommended screening age for African Americans. This was a title change actually from the editor. And so here I really focus on money because unfortunately more policymakers care about how much money they lose versus I typically care about how many people lose their lives from this preventable disease. And so you'll see I'll talk about, costs are rising at a higher rate and the increase in health costs, and it's cheaper if it's caught early, et cetera. But then at the same time, you can see that the language is definitely changed when I wrote a sister piece in the Minnesota Spokesman Recorder, which is the oldest Black serving newspaper in Minnesota. And I said colon cancer is a disease that no one has to die from. At the same time, or no, rather a year or so later, when Prince passed away, Prince is, from Minnesota. It's a very big deal when he passed away. I wrote a piece called Prince Home State, the land of 10,000 disparities. Most people know Minnesota's land of 10,000 lakes. And I thought it was important. It was very important for me to write this piece because the same place where I had the state fairgrounds is where during this year, Philando Castile was shot down right in that prominent area. And so I really brought home how, racism was something that was really entrenched in the waters in Minnesota. And we've seen that come full circle from George Floyd and the other areas. So also I've done some work abroad in terms of capacity building in parts of Africa as well as Jamaica. And so, 1 year pre-COVID, I was, doing this very prominent talk in the government chambers. At the end, I really reminded them what the risk factors and symptoms were for CRC. And so the symptoms, which you all should be aware of as well, I talked about, blood in your stool being the shape of a pencil, constant state of fullness, bloating, changing bowel habits, like skipping bowel activities for more than 2 days, serious constipation, or even rapid weight loss. But then in terms of the risk factors for CRC, I reminded them the importance of their family history. At the time, I talked about older age, but now we can see that this could just be age, period, because, CRC doesn't discriminate in terms of if you're young or old. Having diets that are low in fiber, high in fat, eating a lot of processed foods, high consumption of red meat, lack of physical activity, obesity, smoking, alcohol, and even diabetes. And I have diabetes highlighted because in Africa, for sure, Coca-Cola is huge. And so, regardless if you're poor or if you have very good socioeconomic status financially, soda is very big. And so I, noted how, consumption of soda is increasing the risk for diabetes, which is also a risk factor for CRC. And so because of the end of this talk and probably this slide, the diabetes and the lack of physical activity really stuck with the individuals in attendance, because they not only threw their sodas in the trash can immediately. These individuals who are leaders in the government, they usually, are in a caravan of Range Rovers. They said, no, we would like to rock to our next activities. And that's what they did. And they were in suits and everything. But lastly, I think it's key to also see how these risk factors play their role in other populations that may be overlooked. So this is some other important work that my team is doing that's currently in press with the American Journal of Health Promotion, where we really looked at factors associated with CRC prevalence among long-haul truck drivers in the U.S. So it's estimated that over half of all CRC can be attributed to modifiable lifestyle risk factors, including, again, heavy alcohol use, obesity, high consumption of processed and red meat, a sedentary lifestyle, and even tobacco use. But little is known about the relationship between occupation type and CRC risk, especially among long-haul truck drivers, also called commercial vehicle CMV drivers, who experience several risk factors for CRC. Even compared with the general U.S. population, truck drivers have higher rates of virtually all risk factors associated with CRC, with the exception of alcohol use. The high prevalence of these risk factors poses significant health risk for truck drivers and also puts their livelihoods at risk. So the purpose of this work was really to determine how, after adjustment for age, an a priori list of potential risk factors were associated with CRC prevalence among long-haul truck drivers ages 21 to 85. Our hypothesis was that long-haul truck drivers with poor health would have a higher prevalence of CRC due to the influence of CRC risk factors experienced by this population. In brief, we found that obesity was positively associated with the presence of diagnosed or probable CRC, reaffirming the findings of other studies. Also, older drivers were more likely to be diagnosed, have diagnosed or probable CRC. Truck drivers with comorbid medical conditions were also more likely to experience CRC, and the strength of this association rose as a number of medical comorbidities increased. Thus, our findings align with our central hypothesis that truck drivers with poor health would have a higher prevalence of CRC. Compared with truck drivers of normal weight, obese and morbidly obese drivers had 4.28 and 4.13 times greater odds, respectively, of having diagnosed or probable CRC, as obesity is twice as high among truckers as it is in the overall U.S. adult labor force, and as truckers have also been shown to have poor diet and nutrition than the overall U.S. adult labor force. It is critical for future research to consider interventions aimed at reducing the impact of obesity on CRC risk in this population. Lastly, our findings may also educate prescribers and medical professionals who perform occupational required exams about increased risk for CRC among long-haul truck drivers.
This life is a gift, a precious circle.
And it's our responsibility, each one of us, to protect that circle and keep it strong.
Part of that means protecting our bodies from cancer.
Colorectal cancer is the second most common cancer among American Indians.
Those diagnosed with colorectal cancer
Who discover it early
have a 90% survival rate.
most of the time. There are no symptoms until it's too late.
Don't wait. Protect yourself from cancer.
Protect the circle. If you're over 50 or older, or have a family history of colon cancer, talk to your doctor about a colorectal screening. For more information on colorectal cancer and screening, contact the Great Plains Colorectal Cancer Screening Initiative, 1-800-745-3466.
I'd like to take a moment to thank the participants who made these studies possible, my community partners, my co-authors, my mentors, my research teams, CRC or survivors and angels that I've worked side by side, that I still work side by side with to do this important work, my funders, Dr. Pamela Jo Johnson for this invitation, as well as her mentorship earlier in my career, as well as each of you. You could have been taking a nap, but you were able to persist through my talk, and I'm very grateful to that. And last but not least, these studies in my talk are supported extensively, yet the content is solely my responsibility and does not necessarily represent the official views of the NIH or any other entity pictured here. I thank you all very much for your time and allow me to demonstrate how it is key for each of us to consider how it is our social responsibility to demolish health disparities.
Thank you very much, Dr. Rogers. Zoomland, please join me in thanking Dr. Rogers before we jump into our Q&A session. And I think we have a question that Dr. Strand submitted. Mark, I'm not sure. Did you want me to read that, or would you like to read it?
I can read it.
Sure.
So I'm here at NDSU, and we're working to address racism in healthcare education with our students by revisiting how we report race. For example, we'll report the epidemiology of a given disease state, and we'll frequently say the incidence or the prevalence among different ethnicities or racial groups. But we've been recently asking ourselves, why do we report it that way? Is it necessary? Is it helpful? And does it communicate something to the students, maybe other than what we had hoped to communicate? So we're trying to figure out how to handle that in a better way regarding educating students so as to be more responsible with how race as a category is handled. The risk, of course, is that we then fail to elucidate the disparities that are present. Appreciate your guidance on how to handle this.
Oh, wow. So, there's been a lot of talk of, health equity, ever since, the public murder of George Floyd. So I commend you that you're even willing to be brave enough to have these conversations. And so I would argue that it's very important to continue to stratify, as even I noted with the work with the COVID study that we did. At that time, people weren't stratifying, so it was very tough for us to find that data. But by finding data that we were able to find, we were able to confirm those things that I showed in terms of disparities that exist. So I'd encourage your team to continue advocating for, for this segregation of race and ethnicity. But I'd also think that it's important to also note it that race is a social construct. So you can't just more than likely it's not necessarily race itself because it's social construct that's contributing to the disparities. It's racism and other determinants of health that must be considered. And so I'll drop in the chat a very important article. I think it came out in the pandemic too. Pandemic makes it hard to remember when stuff came out. I just tell people there's 3 days in a week now: yesterday, today, and tomorrow. So sometime yesterday, this article came out in the chat that was really challenging people to think about how they're reporting on race in all of their studies. And so as you continue to have this conversation, again, I will commend you for, challenging those who want to push back on saying you shouldn't stratify by race and ethnicity, but also be very aware of the contributors of other social determinants of health, such as racism.
Thank you.
Okay. I think our next question comes from Savita, and she's actually a student of ours. Savita, I'm not sure, would you like me to read it, or would you like to read your question?
Yeah, you can go ahead and read it. That's fine.
Sure. So is there a single predictor of success when it comes to good community leaders? And did the leaders in the cutting CRC intervention have favorable backgrounds that made them more or less likely to relay information well?
That's good. So I can tell you there is not a single predictor of success when it comes to good community leaders, but I can tell you a good predictor of failure when it comes to poor community leaders in terms of, I would say I'm really good at community engagement because I've had a lot of failures that you don't necessarily see in these projects. But health disparities is a very lucrative field in terms of funding. So unfortunately, some community leaders are only in it for the money, but that's not a problem that's just on them. There's also a problem of a number of academics as well. And so, with this work, it's definitely work that requires you to be at a marathon runner, not a sprinter, in terms of doing it, because it takes a lot of patience and it takes trust and rapport building, et cetera. So to make sure I'm answering your question there, your first question correctly, there is no single predictor of success, but being in it just for the money is not one of them. That's for sure. But you definitely need that money to be able to do critical work. In terms of your second question, in terms of did the leaders in cut and CRC intervention have favorable backgrounds that made them more or less likely to relate information well? That's a good question. So with the intervention, we're still working on what that actually looks like. But I can tell you from my work with the Somali community, which I didn't talk about today, the leaders having favorable backgrounds in some capacity, period, is key. So one route is that, I thought I've done work with Black men. Somali men should be cool. I should be able to do it too. I just have to be aware that they pray 4 to 5 times a day. So I need to respect that when I'm trying to have focus groups. And I need to make sure I don't have pork because they don't eat pork. And, got to do the work. And I had these fancy flyers and stuff, and that did not work. And even when I had my first focus group, which was like an hour and a half, it was respectful of their prayer time. A lot of people showed up, but the first hour was my students who were fluent in Somali actually talking the participants through the consent form, because these men who were 50 plus couldn't read or write in English or Somali. So there's so many other factors that you got to consider when you're doing this work and working with community leaders that can give you a heads up before, maybe sometimes, but sometimes they can't. But in terms of getting more people involved in the future, I had an individual, Mr. Sheik, who I called a community champion in that piece. And Mr. Sheik was the one who told me okay, you had it at this FQHC that has the lowest screen LC completion rates in the state. But maybe you should consider having it in the community center. And that was great. And that was great feedback. And then he also noted that, okay, you had the issue with people not being able to do the consent form, taking up a lot of time. Let's do that beforehand over phone. And, all these other different factors that are key. And so having a community leader that is respected in the community is definitely a predictor of success when it comes to doing any type of community engagement work. And in terms of, if you're the person who has expertise in CRC or whatever that you do, that can be something that can tie with the power of the community leader to still make an impact. And so what I mean by that is, even though I wasn't fluent in Somali, I led these focus groups, and I had a student who was my translator, and she was actually even a female. And the students weren't even concerned that she was a female. They were concerned that her Somali language wasn't as strong as it should have been in their mind. But even with these participants, they were very thankful that I came, because they saw and was doing that because they saw so many people around them dying from this preventable disease. And so, at the end of the day, if you are really in community engaged work and your heart is really in it, people will see it and people will thank you for it, regardless of what you look like, regardless of your race, ethnicity, et cetera. So hopefully that answers your questions. Great questions.
Other questions that participants might have for Dr. Rogers. Feel free to unmute yourself or to put your question in the chat. And actually, I have a question for you, Dr. Rogers, if I might. Can you speak at all to colon cancer detection rates among patients that are of the same race as their physician, or trust levels among patients that are of the same race as their physician?
I don't know that literature by heart, but I have definitely seen some studies that have confirmed for colon as well as the maternal health area in terms of Black women, that there's leaps of bounds in terms of having same providers as increase their risk, not increase their risk, but increase their odds of surviving. And so that's definitely something important to consider in terms of what we must do as a world, really, to change that narrative.
Thank you. Other questions? Feel free to unmute yourselves.
If you had a magic wand and an unlimited bucket of resources, where would you focus your research and why?
Oh man, that's so good. That's so good. Even as you said, I get excited. I was like, you know where I can get this magic wand and this bucket of free money? Wow. Man, I would connect with some economists. I would connect with like some senators in exchange for like, because there's a number of like politicians who are for CRC. So I would connect with them and making sure that I could making sure that I could put money towards their campaign. NIH grants ain't letting you do that, but I would, allowed to be able to do that. And so I feel that by doing that, I could really change the narrative such that not only could we potentially lower the screening age to like 30, which I know there's one state that's trying to do that, but we could also provide more funding, not only for early onset research, but also for people that get lost in the system that have early onset CRC diagnoses. So like I know so many people. Like I know so many people that have passed away. I know so many people personally. Even with my IB8 CRC study, I have 6 colorectal cancer survivors on my team that are helping me, translate this work, et cetera. But I think that, if I had this money and I could have these different partners to do the work that I want to do, these people who have been, I have one colleague in Florida that she saw 20 doctors before she saw a doctor so she could get her diagnosis of stage 3 CRC before age 50. And so like, I feel like with money and the right people at the table, we could eliminate those barriers such that that's not the case for her, and such that it becomes more of a common thing that people know that colorectal cancer is no longer an old person disease, and that we really need to provide the resources and the support and insurance. And, if someone doesn't have insurance, providing resources for them such that they can make it happen. I have a colleague that I'm collaborating with in Canada for the IB CRC study. And it's always good to get her perspectives because they have free healthcare in Canada, but that's something that we don't have here. So like, I would also use some of my magic wand in my pot to give free healthcare to everybody as well. So if I wasn't ready for this, so hopefully this is being transcribed. This is the only award that I'm going to be able to use my big grant for. So please put an asterisk and say, Dr. Rogers has more stuff that he can use his money for, but he needs a little bit more time on such short notice.
Dr. Rogers, what are your thoughts on some of the new type of screening tests that are out there and the performance in different races? Are those tests generally in clinical trials? Are they evaluated in different races?
Yeah.
Is the performance and effectiveness of those tests equal across different races?
Fantastic question. It's like about 6 questions in one, but I'll try to answer them all. So first response is, to me, the best screening test is the one that gets done. First of all, I don't care if you're doing the stool-based exam or the blood one that's to come, or a virtual colonoscopy, the best one is the one to get done. And so with what you've noted, these other ones, they have definitely been progress, and there's RCTs, and a lot of the people who make these, they reach out to me directly for my insight. And I tell them that you can have these great tests, but how you communicate the need for people and how they're going to use them is a game changer. So what I mean by that is that, like, there's one that's coming out that's like blood exam that can like maybe detect like 30 plus cancers, CRC being one of them, et cetera. If you don't acknowledge Tuskegee, Henrietta Lacks, all these other, poor failures of the use of people's blood and cells, et cetera, for research, Black people, for instance, are not going to use it. you know, and even with like Somalis, when I did that CRC work, they can't distinguish between the different types of cancers. They lump them all together. So you have to like think about that. You have to think about how with Somalis also, they feel that cancer is something that results from sin, you know, being disobedient to their God, which is a lot. So like making sure that how you present things are culturally tailored to a different population is key, or otherwise nobody's going to do it. Most of the people that are going to do it are unfortunately going to be people that are white and make good money.
Have you found it helpful to try to incorporate maybe some free tests or something when you're engaging with different populations, or does that not really work?
Yeah, so that's actually the next step of Cut CRC. It's definitely going to be free fit tests that we're going to be giving out more likely to barbers, because we're thinking about how to overcome masculinity. So with the fit, those are fecal-hemochemical tests. They're a type of stool-based test for CRC. They're less invasive, do it in the privacy of your own home. They're way cheaper, like maybe $20, $30 And so even with that, those are something I'm getting donated from some of the advocacy organizations that I partner with. And so those I think will be very helpful with the community. The barbers have also told me that. But the thing that I think is more of a concern is if we have an individual who gets one of these free kits who doesn't have insurance, then what happens to them? I can cover the kit, or a partner can. I can cover the processing of it. I can make it so that you can take it home, and we already got it self-addressed, so you can stamp and mail it off to where it needs to go to get processed. But if they have a positive fit, I know places like Minnesota, there's groups like Minji Gastro, et cetera, that would donate colonoscopies. But like for here in Utah, donations are not charity care is not a big thing. I have some collaborators and a mentor who are willing to donate colonoscopies, et cetera. But those are different things that we must consider going forward, how we will address those potential barriers down the road. Because I feel like an individual should be covered from start to finish. You know what I'm saying?
Yeah, thank you for that.
Thank you for your questions.
The other question, and then I'll stop monopolizing time, is in terms of, so you've identified some cultural issues that may be at play here. So has your team thought about things like incorporating education earlier in a person's lifespan, as opposed to just at the time where they might be encountering an issue? You know, there's a lot of recent work in things like child books, and sort of introducing some of these ideas, or a change in concepts and ideas from an early age to make some of the topics on people's mind and be easier to discuss if they've been introduced to it at an early age.
Yes, yeah. So I've been thinking about that for a long time, because even with the state fair work, I didn't share this slide, but only 2/3. It wasn't significant, but only 2/3 of the participants, which was over 300, nearly 300, only 2/3 of them had adequate knowledge about CRC. Because like I give like this true false exam, and education scales, they're always finicky anyway. But anyway, like 2/3 of the individuals like basically got like, I think a C on that survey. And so it asks things like, if you have blood in your stool, that could be a sign of CRC. People didn't know that. And people didn't know about the screening age should be low over 45 when I was doing that work, et cetera. So I've always thought about this. And the biggest thing with the early onset space is like, there's so many politics that like with my I Beat CRC study, as well as the hotspot paper with, where I, found a place where Chadwick Boseman lived, et cetera, was a hotspot. Like that paper, it was rejected 6 times. It was rejected 6 times. The 7th time was accepted with no revisions. And like now it's like got all these articles about it, et cetera. And then even with the I Beat CRC study, it was rejected for funders numerous times too, because people was like, oh, no, it's not big as an issue with younger people. But the more and more that I and many others keep, sounding our trumpets, people were listening. And so I would love to do more with this work, but getting it funding like by foundations in the NIH, I have to be strategic about how I do that. Because say I want to increase knowledge to increase fit screening, stool-based screening for CRC. There's going to be reviewers that said the screening age is 45. Why are you looking at it? And I can cite all the studies for young people, and I can say how ages 20 to 49 is going to be the number one. CRC is going to be the number one cancer killer. I see like. It's like if you see a truck coming down the road and you're standing in the middle of the road, typically you would get out the road or hope someone would pull you out the road. But it seems like with the NIH, don't take my money away, NIH. I'm just, this is a candid conversation. Like they would be on the same road that most of us as researchers are, because I feel like we see problems before they become, catastrophes. So yeah, I'm getting so caught up in all my thoughts that I can't even get my thoughts across to you. But yes, I have thought about this, but I just haven't determined the best way to strategically do that to get a whole lot of money to really make a difference that is for something that's sustainable. You see what I'm saying?
Yeah. Thank you for that.
That's good. That's a good question, just like the magic wand. Thank you for that.
Next question, Dr. Meyer. She had a question related to support programs. What are your thoughts on creating a support program for CRC, like the ones we have for other cancers, similar to Women's Way, for example?
Yeah, so I know I have a colleague, you may have seen him. His name's Trevor. So Trevor, he's a stage 4 CRC survivor. He's thankfully NED doing pretty well. And so me and him are finally connecting at the end of this month because he started a program called Man Up to Cancer, which is a support program for men with cancer, period. Because he was noticing from when he was doing his experience, there was all these different support groups, but there really wasn't one for men. And so with him, I'm really trying to have conversations with him to help him get this out into the literature to get more awareness of these type of programs. Because I think they are very huge. For me, even being, a cancer researcher, but also a cancer caregiver in the past, support is critical. Even as I mentioned earlier, how social support is key for, encouraging behavior change, I would argue that it's also even more important for survival. With the hotspot work with Utah, it's so fresh, I can't give as many details as I noted, but I talked about how, married individuals had more, higher chances of surviving versus in single people. And so in that paper, we really argue how there should be more support programs for individuals who may not have those well-established social support networks, so they can ultimately have higher odds of survival too. So hopefully that answers your question, Dr. Meyer.
I think we have time for one more question if somebody has a question.
How do we get to national health care?
Talk to my colleague that got the magic bucket. That's how we get there.
I'm putting a link in the chat for you for your amusement. It's comparing the U.S. and Canada. See, we live about 100 miles from Canada here, so a lot of flow back and forth. So one of the popular things to talk about in North Dakota is how terrible Canada's healthcare system is because it's socialist, and yet everybody in Canada defends their system quite strongly because of so many reasons. So there's an article in there, BBC recently about that. So I agree with you, and I hope you continue to use that. You use your platform to advocate for that, as we are trying to do as well.
Thank you so much. And if you get a magic bucket, just send me a message.
Well, Dr. Rogers, thank you so much. I think what we've taken away from your seminar today is that we should have invited you for a full day training because we can learn so much more than, just trying to confine you within a 90-minute space is not enough. So I'm hoping that you'll accept potentially if we invite you back because this was incredibly interesting and we all want part of that magic bucket too. So if you happen to find that, feel free to spread the word. So thank you very much. Everyone join me in thanking Dr. Rogers.
Thank you. Can Dr. Pamela Jo Johnson provide any final thoughts?
I have watched you from your very beginnings trying to sort of navigate the how do I, make those connections with community and community's not behaving. So how do I get this work to go? And looking at sort of how you have worked forward with all the things you're doing, how you're integrating. I loved that slide you put up where you had the columns of here's the first phase and here's the next phase. You know which slide I'm talking about?
Yeah, integration and mixed methods slide.
And I was thinking about that, and I actually will talk to you about this a little bit more later when we chat again. But I think the importance of how you have integrated everything you've done. It hasn't been, I've done this, I've done that, and I've done this. It's like everything fits together, everything informs the next thing. And I think that's just such a great example for all of us, that the importance of building that approach, that work. But honestly, just watching, when I first met this man, I said he's going to be a rock star. And we used to joke that someday he was going to be our boss. And I'm sort of seeing that, you know, he's going to that phase and that stage. And I appreciate Andrea. I agree. We could bring him back for an entire day of all sorts of things, whether it's mixed methods or community-based participatory research, or, you know, you've just got such a great wealth of expertise, but also a great ability to tell stories and to share your work with people, and a passion for getting your work out there. So I congratulate you and I thank you for being here. It's just wonderful to see all that you have done and are continuing to do.
Thank you so much.
Thank you. Before everybody heads off really quickly, I just wanted to remind, we do have a March seminar as well that's going to be towards the end of March, on March 25th, and Dr. Strand will be presenting on the ONE program. Are we really having the impact we think we are? The re-aim model to evaluate impact of the ONE program.